I am going to be talking about dialectical behavior therapy, also known as DBT. The founder of DBT is Marshall Linehan, who in 1991 began developing a theory that would treat chronically suicidal individuals. However, in order to receive federal grants, the therapy had to be associated with a diagnosis. Linehan then pivoted to focusing on borderline personality disorder, also known as BPD, as many individuals with this disorder are chronically suicidal. Treatment initially focused on problem-solving skills alone, but clients felt misunderstood and criticized and dropped out of treatment. Linehan then shifted the treatment to focus on warmth and acceptance, but clients found this to be ineffective. Ultimately, treatment changed to focus on the tension between change and acceptance and radical acceptance of the client by the therapist. One of the basic tenets of DBT is that people with BPD have a disorder of emotional dysregulation. Individuals with BPD tend to have a heightened emotional response system. This may be the result of biological vulnerabilities or negative early childhood experiences. People with BPD have abnormalities in the amygdala and the anterior cingulate cortex. People with BPD have an emotional system which responds to stimuli from the environment with greater speed and strength, which leaves them vulnerable to increased cognitive and behavioral dysregulation. There are 5 areas of dysregulation. Affective dysregulation, which manifests in reactivity of mood and inappropriate expressions of anger. Behavioral dysregulation, which is manifested in impulsivity and such as recurrent suicidal behavior and self-injury. Interpersonal dysregulation, which is shown by unstable relationships. Self-dysregulation, which is manifested in an unstable identity. And cognitive dysregulation, which is shown by the experience of dissociative symptoms or paranoid ideation. Another part of the theory of how BPD develops is that individuals with BPD have experienced invalidating environments as children. These invalidating environments include parents not helping their children learn how to regulate their emotions and invalidating their emotions. Also, 66 to 75% of individuals with BPD have a history of child abuse. A main tenet of DBT is the use of dialectics. Dialectics are visible in the interconnectedness of the world, such as the actions of the clients will affect the actions of the therapist, which will then affect the clients. Dialectics are also seen in that truth is a synthesis of differing views. Dialectics also posits that change is inevitable. Another major tenet of DBT is the use of mindfulness. Mindfulness practices are considered the core skills of DBT. Mindfulness involves increasing awareness of oneself through mindful observation, description, and participation, and the ability to control the focus of one's attention on the present moment. Mindfulness also involves taking a non-judgmental stance, focusing on one thing in the moment, and identifying what works. The wise mind state is key to mindfulness, and this is manifested as the ability to find a synthesis between emotion brain and logical thinking. Solutions can be created by applying the ability to mindfully attend to one's current emotional state to identify the associated cognitions and the actions and reactions of self and others. DBT posits a biopsychosocial model of BPD. According to this model, BPD is primarily a dysfunction of the emotional regulation system, which is interdependent on cognitions, behavior, interpersonal communication, and self-identity. Accordingly, arousal in any one of or more of these systems will result in dysregulation in the other systems. The relationship between the individual and their environment can modify the levels of dysregulation. Invalidating environments can lead the person to distrust their own emotional reactions to events, resulting in self-invalidation. The person is then left with a complex and intense emotional internal world over which they have no skills to understand or manage their experiences. Change occurs by acknowledging the dialectic relationship of not wanting to engage in a behavior, but knowing one needs to in order to reach a goal. Clients can then integrate the opposing notions of acceptance and change, and therapists can teach clients how to regulate their emotions and behaviors. The client is viewed as they are doing the best they can and that they want to change. However, clients need to do better, try harder, and be more motivated to change. Also, clients who are chronically suicidal are viewed as having unbearable lives. Lastly, patients must learn new behaviors in all relevant contexts, and they cannot fail in therapy. As far as the counseling relationship, a strong therapeutic alliance is key. The client and their previously invalidating environments must be validated. The therapist must be warm, accepting, and non judgmental, but must also set firm boundaries. In addition, the therapist is viewed as a teacher, and much of therapy is didactic in nature. The client and therapist meet individually once a week to focus on problem solving skills and DBT skills training. The therapist and client then have a telephone session once a week to firm up skills. Also, the client engages in a weekly skills training group where skills are practiced and learned. As far As far as the populations best served, the theory was created to work with clients with BPD. Studies have shown that individuals with BPD who were treated with the full program of DBT, which includes individual therapy and group therapy, experienced a reduction in the frequency of suicidal behaviors, a reduction in the number of days clients were in an inpatient hospital, a reduction in anger, and gains in social functioning. Studies have also found a reduction in suicidal ideation, the expression of anger, the feeling of hopelessness, and depression. Studies have also found that those who attended DBT had fewer dropouts from therapy, had a reduction in self-injurious behavior and in impulsive behaviors, and that DBT is effective for people with BPD and substance use disorder. The full program has also been found to be effective for individuals with cluster B personality disorders, individuals with PTSD, and individuals with eating disorders. Studies where individuals have received only the group skills training sessions have shown promising results for people with bulimia, binge eating disorder, major depressive disorder, bipolar disorder, ADHD, problem drinking behavior, oppositional defiant disorder, and intimate partner violence perpetrators. There are 4 stages of treatment in DBT. In stage 1, the focus of the treatment is to stabilize the client and to hone in on behavioral control. This includes decreasing life-interfering behaviors such as suicide attempts and self-injury, decreasing therapy-interfering behaviors such as missing treatment, reducing quality of life interfering behaviors such as substance use and homelessness, and increasing the use of DBT skills. In stage 2, behaviors are controlled, but emotions are not. The goal of this stage is to experience the full range of emotions non-judgmentally. Stage 3 involves reducing regular problems in living, and stage 4 is when the therapist helps the client to find joy and a sense of wholeness. Treatment is separated into 2 parts, which are solving immediate problems and learning and practicing skills. Both of these occur during individual therapy, whereas skills training is the focus of group therapy. Skills training is separated into 4 modules. The first module is mindfulness, and these are considered the core skills. One skill is learning to live in a state of wise mind, where the emotion mind and the reasonable mind are synthesized. Another skill is observing and describing what is observed. This helps clients learn that they are not their emotions and that they need to accept all their emotions. Clients learn to be non-judgmental of their emotions and situations and learn one mindfulness, which is where they focus on the moment. The second module is interpersonal effectiveness. These skills teach clients to manage interpersonal conflict, develop new relationships, and end destructive ones. One technique is applying the acronym DEAR-MAN to learn how to make requests effectively. The acronym stands for describe, express, assert, reinforce, be mindful, appear confident, and negotiate. Another skill is taught that helps clients learn how to say no effectively. Emotional regulation is the third module, and this is focused on learning how to reduce unwanted emotional responses and increase desired emotions. Here, clients are taught how to identify and describe their emotions, how to change emotional responses, how to reduce vulnerability to negative emotions, and how to manage difficult emotions. One technique used is opposite action, where clients act in ways opposite of what their minds and bodies are urging them to do. Another technique is cognitive modification, where clients learn to check the facts. Here, unjustified emotions are challenged and replaced with rational thoughts. Another technique is to cope ahead. This is where clients imagine coping to a difficult situation that may occur in the future. The last module is distress tolerance. Here, self-soothing techniques are taught, such as the acronym TIP. This stands for tipping your face into water, intense exercise, paced breathing, paired muscle relaxation. Clients are also taught reality acceptance, where they learn to radically accept their emotions and situations. Two of these techniques are half smiling and willing hands. Both of these come from research that suggests that facial and body language can influence your emotion. Studies have shown that after treatment, people with BPD had significant deactivation of the amygdala, a significant deactivation of the anterior cingulate cortex, and decreased activity in the inferior frontal gyrus, all areas which regulate emotion. And here are my references. Thank you very much.